What does pre-stroke neurological health have to do with recovery in patients with dysphagia? And how does this influence their prognosis and therapy? Find out more coming up. Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia care. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for conversations aiming to bridge the gap in dysphagia education and practice. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. Through critical reasoning and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Today's episode is sponsored by Bracco Diagnostics, the manufacturer of Veribar barium sulfate products, the only FDA-approved barium products for the modified barium swallow study. Learn more at Bracco, that's BRACCO.com, or VeribarMBS.com. Welcome, everybody. This is Dr. Janina Wilmskoetter. She's an assistant professor at the Medical University of South Carolina, and you can't see her, but she's laughing at me at my production of her name because I'm trying so hard, and apparently it's not good enough, Janina. Is that right? Or is it just too perfect?
Fantastic. It was fantastic, Jim. Yeah.
All right, I love
Even
it.
better than the German pronunciation. So.
Even better. I'm trying so hard. But Janina, she works as a researcher, an instructor, and in the clinic, in an acute care clinic at the Medical University of South Carolina. We recently recorded an episode with Julie Blair, who also is at the Medical University of South Carolina. So check that one out too. But that's not why we're here today. Janina, why are we here? You published something. Tell me about it.
I did. It just came out, actually. So it's an article that's titled Cerebral Small Vessel Disease and is an independent determinant of dysphagia after acute stroke. I had to read this right now. It's not that I remember that by heart.
Yeah. So then there are a lot of words. So cerebral small vessel disease is an independent determinant of dysphagia after acute stroke. So I'm guessing that's what you found. Just a guess.
I learned from a professor, if the title is a question, then it's very, very likely that they didn't find what they were looking for. And here we already give the answer. So you actually don't have to read the article if you don't have time. Just read the title. That's
nice.
Right.
Not even the abstract. You don't even have to dig that.
No,
just the title.
No, just the title.
Okay. Yeah, we've got a lot of names of people on here who've worked with you. Bonnie Martin Harris, I recognize that one.
Yeah.
No, this is fantastic.
Yeah.
It looked like a collab between the University of South Carolina, Northwestern, and the Medical University of South Carolina.
Yeah, I was lucky because when I did my PhD at the Medical University of South Carolina years ago, Dr. Heather Bonilla, Leonardo Bonilla, and Bonnie Martin Harris were on my committee. So I was really, really fortunate. And this data that I've analyzed was actually part of the patient data that I collected at that time. It's expanded, it's part of it. So, yeah.
Oh, very cool. Very cool. So it's an interesting subject. And as I was looking through it, I like the fact that it not only looked at new stuff, someone has a new stroke, you're looking at these people who had their first stroke, but you're looking at all of these premorbid indicators. So I'm very curious about what prompted you to do this. What was going through your head?
Right. This is a really good question. It's there are nice pictures in the article, but why do we need this? So I worked as a clinician many years in acute care, and my passion is stroke, so neurological injuries. And when I worked as a clinician and still do, there can be two patients with the same stroke lesion location. So on paper, they look pretty the same, but then you walk into the room and they present really differently. One patient has dysphagia, the other one doesn't really present with dysphagia. And my prior work in my dissertation looked at how much can we understand from the lesion location, lesion size, etc., to predict what swallow physiological impairment is there. So my entire dissertation was on, let's look at the lesion location and see what impairments are correlated with this. But in clinic, to some degree, we can use that information, but then we see these patients, well, they have the same lesion location, but they present differently. So there must be something else that contributes to why some patients present with more severe or with no dysphagia. And there are, of course, lots and lots of different factors, but one factor that we understand from our recent literature overall in stroke seems to be the brain health before the stroke. So, how healthy is the brain that then gets an injury? And that has been looked at in other stroke functions like language, so aphasia or motor recovery. And there seems to be really good correlation that it is a contribution of like how healthy you go into the stroke. What kind of makes sense, thinking also about analogies like if you have pneumonia on a pretty healthy lung that's probably not as damaging or detrimental compared to someone who already has COPD or other damage to the lung, then gets pneumonia on top of that. This person will probably struggle more in terms of the severity or recovery. And that's what this brain health term tries to get at when we think about like a brain can be structurally more healthy or more diseased, but also this will turn also into the function that the brain can produce. So that's kind of the idea. If things can explain or help us explain how someone presents after a stroke, that relates to their brain health before the stroke.
And you do a great job at explaining that. Like I feel like I'm following right along. And so that brings me to like, if you're working with someone with pulmonary issues and has dysphagia, there are things like you mentioned, COPD, that you look for, or you'll look at. So you look in their medical history, you'll look in the chest X-ray or chest CT reports to get a better idea of some of those chronic issues that may impact their healing and recovery. What types of things did you speculate, or what types of things did you look into that would be similar markers for neurological health?
Oh, yeah. And of course, there's not like one definition of like, this is how we should measure brain health.
This is a healthy brain. Looks like this.
Healthy brain. Like, so what is a healthy brain? And hey, surprise, everybody has a different definition for that. And then we took a definition that has been more recently used also in like standard radiology guidelines. And this is small vessel brain disease. This is just one marker how the brain structure changes over time with age. Other functional definitions could, for example, be, I don't know, intelligence, right? Is that maybe a marker for healthier brain, someone who is more intelligent, but how do we measure intelligence? So we can like have these discussions. We only looked at structure in the brain, and cerebral small vessel disease is one marker that is like a standard measure, and you will see that in your MRI reports of any patient that you have in the hospital who got a brain MRI, and often it's something worded like T2 hyperintensities or unspecified T2 hyperintensities, likely cerebral small vessel disease. So this is like kind of the terminology that you will see. But the big thing is that based on that, you normally don't get information on how severe is that. Is that just really mild? Is that something I should care about? Sometimes you might see expressions like atrophy in the MRI. But the interesting thing that when I started with this research is that there's a huge variabilities, huge variance about how a brain ages. Kind of makes sense, but I never like translated that, yeah, the brain as well. And some of the normal things that happen when we get older, no matter if there's an underlying disease or not, is that, yep, our brain atrophies. So the gray matter, white matter shrinks, and that's counterbalanced by an increase in cerebrospinal fluid, and that's what we term atrophy. So yes, we all go through that, no matter how healthy or unhealthy we are. But the crux to that is that it's very variable. So two people who are 80 years old can have a very different degree of atrophy. So one person might have severe atrophy and the other person doesn't. And I think you can again translate that to someone who's 80 and really active. I heard some people still run like, I don't know, half marathons in that
Oh
age.
dear.
It's probably
Ooh.
not going to be me, but there's a
Not me right
huge,
now.
right?
I could never do
There's
that.
a huge variance of like how people age. And that's the same idea with the brain. So cerebral small vessel disease is a term that encapsulates like many different structural pathologies in the brain. Atrophy is one, microhemorrhages, so like little tiny bleeds in the brain. And then another marker of cerebral small vessel disease is something that's called white matter hyperintensities.
Yeah.
And it's exactly what the name says. When you look at a brain scan, a specific brain scan that's T2 or FLAIR, they look just really bright. So these are areas that look white compared to the other tissue. And we can go more into what that might be. And then also something like called perivascular spaces. And these are just spaces around the arteries that perforate the brain. So, and you can imagine, so these spaces around the arteries, they are filled with fluid. And the larger they are, they take up more space in the brain. And it
Sure.
seems to be a marker that the brain might not be as efficient to drain some of the dust or the debris in the brain tissue. So all these things are like different markers that the brain has cerebral small vessel disease. So to the small vessels in the brain, that they are not functioning as well as they might did when we were younger. But the thing is really like, how much does a person have that? We're probably all going to have it at some point, but some people will have it more than others. And these are findings that are typical incidental. So you don't know that you have
Sure.
that until
Yeah.
you get a brain scan. I was like, oh, wow, there's a lot of white matter hyperintensities. And so while it's not something that you feel from one day to the other, it is something that probably contributes over time to specific functions like swallowing or memory, because it's one of the major contributions to also people developing dementia.
Yeah.
For example.
So I know people who are listening to this probably in their car and in a place where they can't really like sit down and look at a diagram, but this article is open access, and I would highly recommend taking a look at some of the images in here. These are fantastic. So the comparison, so you were talking earlier about the increased volume of cerebrospinal fluid that kind of compensates for the brain atrophy. Like you get brain atrophy, and so the parts of your brain, I want to say that matter, but that make us smart or healthy.
Gray matter and white matter, Tim. Was that a pun?
There you go. That matter. No, yeah, sure it was. I guess I'll pretend that it was. But so, as you get atrophy of those, then you get more cerebrospinal fluid in there. So figure 2 is super cool. There is patient 1, 68-year-old female, 0.25 liters of cerebrospinal fluid, and then patient 2, also 68-year-old female, with a little over twice that. Man, you can tell a difference. This is so interesting. So if you get a chance, take a look at figure 2. A quick reminder of our sponsor. Bracco is a global leader in diagnostic imaging, dedicated to providing you with the most advanced tools and diagnostic imaging solutions. Find out more at bracco.com or veribarmbs.com.
And I've never learned as a speech language pathologist to look at MRIs, right? So I was fortunate to learn that during my PhD and postdoc. But it is also interesting that the people or the patients that we included in the study, they all were a pretty clean cohort. So first ever ischemic stroke. We excluded anyone with like prior diseases that could relate to dysphagia. So no neurodegenerative diseases, no head and neck cancer, no other stroke before that, no TBI, right? So all these like typical things. So these are supposedly people who were healthy before they had the stroke. But again, all this, what we see in these like examples were pathologies that were there before the stroke. Wow. So it's not something that's related to the stroke because these patients were acute stroke patients. It was something that was there already before the stroke. But again, not something that was apparent because it didn't cause acute symptoms.
Yeah, and maybe not even something that people would recognize symptomatically over time. So, like
Mhm.
if you're interviewing someone's family, be like, well, did they have dementia before this? They might not have any indication of memory loss, so you might not get it without this imaging.
Yeah,
Wow.
correct, correct. And I mean, it's not something that we would, I think it's like human nature, right? If we don't feel limitations, not functional loss, so why should we look
Yeah,
into that, right?
sure.
But yeah.
Well, that's fascinating to see where that kind of comes to bite you later, for sure.
Yeah.
Oh, so as a clinician, because you worked as a clinician for a while
hmm
before getting your PhD, is that right? So
Yes.
I figured this was pretty clinically driven. What are some of your takeaways? Like, how do you think you're going to use this from now on?
Yeah, great question. So what is always the best question I got as a researcher, right? Well, it's great research, but so what? I think it helps me as a clinician when you do a chart review, and we do that thoroughly. I think we are used to looking through like doctor's notes, we look at chest imaging, we read the notes from the MRI or CT, what we have. I hope it helps to get a better hypothesis of what you might see when you walk into the room. And I think it's also, we haven't proven that yet, knock on wood, that this research is continuing, but it will likely be a marker for recovery as well.
That's what I was
So,
going, a prognostic indicator
oh,
potentially. Not, oh,
yes,
wow, there you go.
there we go. So we showed that in aphasia, actually, so language disorders after stroke, that patients with worse brain health, measured as cerebral small vessel disease, had worse potential to recover despite treatment. So, and that's controlling for their chronological age. What's really fascinating. So, it's not the chronological age, it's really the brain age. So, how healthy is the brain at the time they receive treatment? And so, if you walk into a room and patient presents with dysphagia, then it's always the question of doctors, hey, so do you think this patient recovers, or do we have to think about putting a feeding tube in because we really want to discharge this patient? And then as a SLP, I always feel like I wish I had an answer, but why don't I have an answer? And I think this is a factor that comes into play that we can say, yeah, okay, so the stroke lesion location, we know this will lead to whatever severity of dysphagia. That's what we're going to see at bedside. And if we have an idea of the patient's status before their stroke, how healthy were they? How healthy was their brain before the stroke? This can help us to say, oh, the chances are actually really good for this patient to recover because they had a pretty good brain structure before that. So, and that's, I think, lends to our discussion, Tim, about the reserve that someone has to recover. So, how much capacity does a patient bring to, for example, for the brain to reorganize after a stroke? So, what we know from dysphagia literature, and Shaheen Hamdi, I love his research and his group around that, brought us a lot of knowledge that after dysphagia in one hemisphere, the other hemisphere is likely to help a lot in recovery and also like areas around the stroke. But imagine if those areas that were not affected by the stroke, but are supposedly to help with recovery, if they are not healthy, then the brain won't have the same capacity to reorganize or regain that function compared to a brain where these unaffected areas were pretty healthy and had a lot of white matter connections, had a really good volume of gray matter. So we're just like, there are more neurons that can change. I hope that made sense. Did this make sense?
I
Somewhat?
no, you're making sense, but my brain's also going in different directions with questions, and I'm like, I'm afraid to ask these questions because I should probably know some of these answers, and like it's
God,
probably
maybe
already
I
been
don't know
studied
the
before.
answer.
Well, who knows? Who knows? I guess I got to put myself out there some. But I mean, I'm thinking of so as I understand kind of what you're saying, and I'm looking at another one of these beautiful images. It is figure 4. So this is cool. Figure 4 has it highlighted the corticobulbar tracts in the right and left hemisphere, going over from the motor cortex down toward the brainstem. And it shows different lesion sizes and different lesion locations. And on this, it's showing some of them basically the lesions covering where the corticobulbar tracts would be. And so as you're talking about the recovery, like so say if the left side is affected, the health of as I understand what you're saying, the health of the right side of the brain in its ability to kind of take over some of these functions. Well, the premise being is that it will help to compensate, and the healthier it is, the better it's going to be able to compensate, right? That's what I'm getting. So I'm thinking about all these poor folks with spastic dysarthria who they have like bilateral damage to the corticobulbar tract. I'm so sorry. And so like thinking of that as a prognostic indicator, I'm sure there's probably research out there that says that I should know that I don't know enough about, at least.
And Tim, let me plant a seed for the audience, because I saw that you had the post about dysarthrias, and dysarthrias are not my strengths, though I love the post that you included in your Instagram, I think.
Oh, thank you. Yeah, though dysarthria has been very interesting to me, the various types of dysarthrias. And I was very fortunate to be able to start teaching this course at the University of Hawaii, but it's not, unfortunately, I didn't get to go there. It's remote, but I learned so much. So Dr. Kendrea Grand, as you can imagine, has a very robust dysarthria course or motor speech disorders course put together. And so she sent me her materials and I got to look through them and get some other things, but I learned so much going through that, and just like the parallels with dysphagia treatment, the upper motor neuron or bilateral upper motor neuron lesions causing spasticity, and how you might treat that differently than somebody who has a lower motor neuron lesion. And the analogy I use is like you've got a cord coming from your power outlet going to a lamp, and someone just cuts the cord. Like it's not getting power anymore. So just the flaccidity, the weakness, that type of thing. But so you see, like I can see so many parallels between this and dysphagia. So it's just like my world has been blowing up in that perspective lately. So I just think it's super cool. Very interesting.
It is. And because my background is also like in aphasia, so language disorders, I often compared also like how is recovery working in aphasia compared to dysphagia, dysarthria. And I think what is really striking is like how much in these functions do both hemispheres contribute. So we know that the typical language organization in the brain is heavily towards the left side of the brain in those typical people, right hand dominant, etc. The right hemisphere is also involved in language processing, but not as much. More like in the ventral stream, so semantic processing, etc. With swallowing, in comparison, and speaking, we know it's a bilateral neural network, and it's less lateralized. So language is a heavily lateralized function, swallowing not so much. So both hemispheres contribute. And to how I think about it is, it's actually great when it's really organized in both hemispheres, because that means if one hemisphere,
the redundancy.
Exactly. So if you have an injury, then the other hemisphere, because it already contributes to that function, it will be easier for the hemisphere to, okay, I'm just going to do a little bit more. I already have these connections. I already kind of know what I have to do. In comparison to something like language that's heavily lateralized to the left, the right hemisphere does a little bit, but not as much. So that's why the hemisphere in language has a more difficult time to compensate. So we don't see that as much. And the areas around the stroke are more contributing in language for recovery. And that's why it's interesting when you pointed out the figure 4. I think long time we always think, okay, brainstem is swallowing, right? Corticobulbar tract, that's really, really important. We know that. And lots of those studies that look at recovery also look at corticobulbar tract. Makes sense.
Oh, and real fast, just I don't want to assume anyone knows anything. Corticobulbar tract, the motor neurons coming from the cortex to the brainstem. So I think corticobulbar is cortex to brainstem, corticospinal is cortex to spine. So for motor neurons.
Yes, thanks, Tim. That's right.
No, I mean, you probably didn't know that either, but I'm just showing off. No. You just study it for a living. So.
Yeah. I was told. So I lost my train of thought. No. So
daggone, I'm sorry.
In this figure, so corticobulbar tract. And in the study that we did with the cerebral small vessel brain disease, we controlled for the stroke damage to these important tracts, corticobulbar tract. So we just wanted to make sure that we can like isolate the contribution of the cerebral small vessel disease, no matter how much or how little the corticobulbar tracts were lesioned, no matter how large the stroke is, no matter how old someone is, et cetera, et cetera. And we, from some other literature, we also know that, yeah, corticobulbar tract is important, but that's not the only connection the cortex has to the brainstem. What is also really, really interesting, and I hope that some neuroscientists who can do much better work than I can do will tell us a little bit more about that in their future research. So what other tracts than the corticobulbar tract can we maybe stimulate through electrical stimulation or whatever that could then even compensate if the corticobulbar tracts are damaged?
That's super cool. It's like cracking open a whole nother pathway for dysphagia rehabilitation.
Yeah.
That's super neat. One of
pathway, again a pun, Tim.
See, it's above my head, over my head. I'm gonna have to listen to that again and be like, all right, I got to learn from those accidental puns. So, well, you were comparing the idea of language dominance, which is typically more isolated to one hemisphere than the other, at least relative to swallowing. And so that, I guess, the kind of a question I'm going to throw back at you, right, is if we're also understanding the cranial nerves that are involved in swallowing and the upper motor neuron tracts that eventually lead to these cranial nerves, and the ones that and this oversimplification, I'm sure, the ones that I look at primarily, trigeminal 5, facial 7, glossopharyngeal 9, less from a motor perspective, but vagus 10, and then accessory, of course. Hypoglossal. I was going to go, I kind of, accessory, yes, of course, but I'm going more like direct, but hypoglossal. So I think so many, we learn that like, okay, brain right hemisphere controls the left hemisphere controls the right, but knowing the importance of which of those cranial nerves are also bilaterally innervating you, like the facial nerve. Especially the upper face, you get bilateral innervation from that. Yeah. So in looking at and trying to hypothesize imaging to function and that sort of thing, to just the importance of knowing which of those nerves provide bilateral innervation.
Yeah, that is so interesting, right? And then the hypoglossal nerve, it's always so fascinating to me that some people naturally have a really prominent bilateral representation, but some people have it more unilateral. So that's why you see in some cortical stroke patients, some have a tongue deviation and others don't, because there's like this mix. Exact physiological mix. Like, I don't know, Tim, do you have it bilateral? I hope I do, but we don't know.
I don't know. Hopefully we won't ever find out, but we'll see.
And I think for dysphagia, cranial nerves are so important, and they give us so much information at bedside to then come up with hypotheses. And again, a shout out to Dr. Garand, who has so much knowledge about this and has so many great educational platforms to help us understand that. In dysphagia, I think what we then, taking it a step further, often also need to consider is, of course, the coordination piece, right? So cranial nerves tell us like the information directly to the muscles. Can we like switch this on, off? But it doesn't tell us if the muscles work in synergy, because that needs to be controlled by other areas in the brain that are not those corticobulbar tracts that give rise to the nerves. And I think that's then, of course, always the interesting piece. It's like, okay, they don't have cranial nerve damage, but present with severe dysphagia, because there are other areas in the brain that help with this coordination piece.
Like the extrapyramidal system, the basal ganglion cerebellar control circuits and
exactly.
And those are so complicated. I'm just scratching the surface with those. To me, they appear so much more complicated than just the direct activation pathway or the corticobulbar and the corticospinal.
Right. Yeah.
tracks.
I think that's why many researchers or many studies, and we as well, look at the corticobulbar tract, because it's kind of like, okay, I get it. But so many other areas in the brain and circuits are contributing to swallowing. Yeah.
Oh, that's cool. I'm having fun.
Okay.
This is why I do the podcast. Like, I learn so much and just have fun conversations. I mean, this is one reason why I do the podcast. The post-production editing, that's a whole different story. But this is happy as a clam. Happy as a clam right
Well, I
now.
am so thrilled that I can talk here today because I'm kind of fan girl of your podcast. So
No,
thanks for having
oh,
me.
I appreciate it. No, this is so Yanina and I met at the Hard to Swallow Catalyst for Change in Dysphagia Management conference. It was 2 years ago. That was a great year. I think that was the biggest turnout that we had. That was so much fun. Don't know the date for that yet, and that's done through Rocky Mountain University, not through Gap Education, my company. But there is a plug though. There is a plug, real fast. I got to take advantage of this. You're talking about Dr. Kendria Garant and her marvelous work on cranial nerve stuff. So in March, we are going to have, or we're planning March, either early March or late March, to have a 3-hour webinar with her to really dive into that stuff. Hoping to record it too. So mark your calendars. Keep that open. No,
I gotta
Yanina will
mark
be
my
there. I'll be
calendar.
there. Yeah, yeah. Well, we'll all be there, right? Where are you going to be? So anyway, that's that. But not to sidetrack us too much. We talked about why you did the study. Why do we care? Why should we care? The clinical translation, cerebral small vessel disease as a standard measure of health potentially related to the brain. What do you think are some of the limitations of the study? Like, what should we not read the study and be like, all right, this means this now?
Yeah, thanks for that question. So this study was a preliminary study, right? And I feel like every study can be titled a preliminary study because always we want to do more. So we only had 40 participants. And of course, the goal is that we increase the sample size by a lot and then continue also the measures in a more sophisticated way. So what the readers will see is like, for example, the perivascular spaces and white matter hyperintensities. We scored them on an ordinal scale. And there are way better ways to do this in a more quantitative way. So take this with a grain of salt, but was that right, video? Great. Okay. And so while we did a lot of analyses, only very, very few survived in the end to be statistically significant. And even fewer survived after very stringent corrections for multiple comparisons. So it's the way that we need to do is that we don't think some of our results are true, even though they might just be an accidental finding or an artifact. So the limitation is definitely a small sample size. And it doesn't mean that just because we didn't find something that it's not there. I think that's what's important. For example, we didn't find a significant correlation between these measures and oral total. That was something I was expecting. So I was thinking, okay, these aging factors, I think what we often see is like oral control difficulties. We didn't find that. However, that doesn't mean it's not there. Right? Just because it wasn't statistical significant doesn't mean that it's not there. So we have to just keep that in mind that maybe our sample wasn't big enough. Maybe our measurements were not as sensitive as they should be. So I think this is really important when you read that study to keep that in mind. And I feel like that we as clinicians are not trained to do these measures that we used in the study, right?
Sure.
I think I had no idea what perivascular spaces are before I did this, and absolutely no idea how they would look like. So it's going to be difficult for clinicians to really know in the patient that they see if these things are present. But just really look at the MRI report and look for these words like unspecified T2 hyperintensities, likely related to cerebral small vessel disease. So I think that's my recommendation. Look for these things and start like thinking about, oh, this might mean that the brain health of this patient wasn't as great to begin with.
Yeah.
Did I answer your question, Tim? Or...
Oh, and more. Yeah.
Okay.
That's great. That's great. No, thank you so much. Is it anything else that you want to leave listeners with?
No, I feel like the clinical driven questions are what is really important to me. So if anybody else has clinical questions, I think that's the way to go, that we should then research to get more answers for when we practice clinically.
Good deal. Good deal. And it looks like your email address is also listed within this article. So if I put it out there, I don't feel quite so bad. Wilmskoe MUSC, like Medical University of South Carolina.edu.
Right.
All right, cool. Well, thank you very much. Really appreciate it. It's great to see you. This makes me want to have you do a 3-hour course after Kendra, or I don't know, sometime. So we should talk about that, hang out, and maybe we'll get something going. We'll see. But thanks again, everybody. Dr. Janina Wilmskoetter, right? Yes. That was okay. Okay. I'm very self-conscious of my pronunciation. Yeah, there we go.
Excellent. Well, thanks so much, Tim.
Awesome. Thank you. That was Dr. Janina Wilmskoetter discussing cerebral small vessel disease as a predictor of recovery and dysphagia after acute stroke. You can reach her at Wilmskoe, that is WILMSKOE, at musc.edu. That's MUSC, like Medical University of South Carolina. And there is a link to today's article in the episode description. Don't miss our upcoming event on February 23rd, Swallowing Cinema. It's an MBS case study event that has been a staple at ASHA for years, and this year it's found a home with us. Visit swallowthegap.com or swallowthegap.com/live courses to learn more. Thanks for listening today, and if you think we're helping, please spread the word. Take care.